Good evening, my colleague. Today we'll start the third online webinar for Emirates Society of Bariatric and Metabolic Surgery. Today we have four speakers. First, Dr. Mohammed Al-Qal'awi from London Hospital. He will lecture us about intestinal obstruction after Roux-en-Y gastric bypass, and our bariatric dietitian, Ms. Fatma, will lecture us about malnutrition after bariatric surgery, especially Roux-en-Y gastric bypass. And Dr. Hissam Abu Sahmin will lecture us about the drug map, how to deal with with type 2 diabetes. And the last one, our colleague, Dr. Haider, will lecture us about marginal ulcer after mini gastric bypass. So we'll start first with Professor Qal'awi about the intestinal obstruction after Roux-en-Y gastric bypass. Please, Dr. Mohammed.
شكرا دكتور طارق. السلام عليكم ورحمة الله وبركاته. كل عام وانتم بخير. And thank you, Dr. Tarek, for inviting me to join this meeting organized by the ESMBS to share a few slides of mine with you. So we'll be talking about the post-Roux-en-Y gastric bypass bowel obstruction. If we're going to talk about bowel obstruction, then probably we need to think about general surgery. And when we do that, then we usually start by thinking whether this obstruction is mechanical or functional. But because we're talking about Roux-en-Y gastric bypass and another cohort of patients, then we should be thinking more and more towards what are the main reasons of having a bowel obstruction after a gastric bypass. According to the literature, then we'll have causes due to adhesions, which is the most common cause. We'll have other causes because of internal herniation, anastomotic problems, or port size. If we're talking about the Roux-en-Y gastric bypass, then probably we need to think more anatomical than function in terms of the possibility of having an obstruction. And if we're talking about Roux-en-Y gastric bypass, and anatomically, we need to think that we have made some changes. We have got a pouch, we've got a gastrojejunostomy, we've got the rolling, and we've got the JJ anastomosis, and then we've got the remnant stomach with the biliary tree, as well as the rest of the bowel, including the alimentary tract. If we're going to go back to the general classification of bowel obstruction, then we can classify them into dynamic, adynamic, small bowel, large bowel, acute, chronic, or sometimes subacute, and then an open and closed loop. And this still applies to the bowel obstruction after Roux-en-Y gastric bypass. Generally speaking, in general surgery patients, as we all know, adhesions is the main cause of small bowel obstruction. Tumors accounts for about 15%, inflammatory bowel disease about 15%, hernia in about 12%, and then the remaining other causes, including tumors, is about 18%. Roux-en-Y gastric bypass specific causes accounts for about 3 to 6% of the patients who will be having a Roux-en-Y gastric bypass. And if we won't think about them scientifically or try to classify them, then I think what would be appropriate is to think about them in either dynamic or adynamic bowel obstruction. If it's dynamic, then we've got the three subcategories of having intraluminal causes, intramural, and extramural. Intraluminal causes will most probably be due to some physical cause of obstruction, commonly blood clots, and it has been reported that some disorders can happen within the GI tract post-gastric bypass. Intramural causes will be in the form of a stricture, which is again not uncommon, tumors, which has been reported, and inflammatory disease of the bowel. Extramural causes of bowel obstruction after Roux-en-Y gastric bypass is the most common subcategory, and it can be present due to adhesions or hernia and rarely interstitial. We shouldn't forget that there's sometimes adynamic bowel obstruction that can happen after Roux-en-Y gastric bypass, which can be due to ILS, for example, either immediate postoperatively or late due to other reasons. Sorry, I do apologize. Or due to ischemic causes like portal vein problems. Now, why do we think specifically if we're talking about small bowel obstruction after Roux-en-Y gastric bypass? Because simply we have changed the anatomy. We've lost the normal continuity of the gastrointestinal tract. We have created a diversion with 2 extra new anastomoses. We have created at least 2 mesenteric defects, and there is always weight loss. So why would you think about weight loss specifically as a reason for the small bowel obstruction or the bowel obstruction after Roux-en-Y gastric bypass? Because if we lose weight, then we have lost fat. And if we lose fat, part of the fat that we're going to lose is the mesenteric or the abdominal fat, which most importantly would manifest in loss of some of the mesenteric fat with the possibility of having either a de novo or a recurrent internal herniation if the defect has been closed. And we also shouldn't forget that when we lose weight, sometimes we lose some of the muscle mass of the body, which will allow for the either naturally happening or new openings within the abdominal wall to be created, which it can present in the form of a hernia. And we shouldn't forget that it's not only that we've altered the anatomy, we've altered the GI physiology in terms of absorption, which can present with some potential deficiencies. And if we think about deficiencies in terms of vitamins, trace elements, then that can lead to some electrolyte disturbances, which can also affect the GI motility and can present with some form of bowel obstruction. And by the way, we should not forget that not every Roux-en-Y gastric bypass is the same, because we as surgeons, we tend to do more or less different gastric bypass. The changes or the differences are not major, but they can affect our incidence of having an obstruction. So for example, limb length, because in the past, a lot of surgeons used to believe by having a shorter biliary limb that will reduce the incidence or stop the occurrence of an internal herniation. That obviously has been proven to be wrong, but that has happened. Some surgeons would do retrocolic rather than anticolic. And there is nothing wrong about doing a retrocolic or an anticolic, although that there are preference for the anticolic row limb. But if we do a retrocolic anastomosis, then we have created an extra hole in the mesentery, so the colonic mesentery, which it can be a cause of bowel obstruction, either by having a compression of the row limb by a loaded colon, or by simply having a herniation next in the mesenteric defect. We also have got the banded and the unbanded gastric bypass, which you can present with a mechanical obstruction of the pouch. And there are also differences in how we create our jejunostomy and the gastrojejunostomy, and I'll come to this later in my presentation. We shouldn't forget that we do sometimes primary Roux-en-Y gastric bypass, and sometimes we do revisional gastric bypass for other complicated or other non-functional bariatric procedures. And obviously, as general surgeons, we do understand that the more surgery we do, the more potentiality of having intra-abdominal adhesions, which is the commonest cause of bowel obstruction. Finally, I'd like to remind you all that we all try to do laparoscopic bariatric surgery, but up until this DNA, we still have got surgeons who might do primary bariatric surgery through an open abdomen, or sometimes we have to revert or convert our laparoscopic approach to open if there are technical problems. Shall we stop talking enough theory and let's get into some clinical cases? This is a very interesting case that I have seen quite a long time ago. I think it's about 15, 16 years ago. This is a Roux-en-Y gastric bypass who has presented like 1 or 2 days after the operation by an obstruction of the gastroesophagus. Very standard operation done by a very experienced surgeon. He used to be my mentor in bariatric surgery, done with a 21 millimeter circular stapler. But unfortunately, because if I remember correctly, because of a small bleeder around the anastomotic side of the gastrojejunostomy, the surgeon had to take 1 vicryl stitch. Obviously, as you can see, This vitreous stitch has been deeper than it should have been, and it has incorporated the posterior wall of the anastomosis and has caused an obstruction. The obstruction wasn't complete immediately after surgery because we used to do an anastomotic leak test, and that was fine during the surgery. But I imagine that 1 or 2 days after the surgery, because of the stitch, the gastrojejunostomy became quite edematous, and this is how it presented with the obstruction. The second case is another fairly common thing that happens after a gastric bypass. Again, a standard Roux-en-Y wide gastric bypass. The patient gets admitted like a week later or 2 weeks or something like this, and we would find a port site herniation. The third case is something that we all have seen, and this is a presentation of a herniation through one of the mesenteric defect. In this case, it was the jejunostomy mesenteric defect herniation with the catastrophic end result of having to resect a bit of small bowel. I've got other pictures of much more bowel that has been resected, but I couldn't find them while I was preparing this presentation, but we all have seen it. The next patient is a patient who had a Roux-en-Y gastric bypass. This is a patient of mine who has presented in day 2 and then in day 3 with abdo pain, nausea, and vomiting. And when we've done a CT scan with some oral contrast, we found that there is dilatation of the biliary limb and what looks like a very narrowing of the JJ anastomosis. And if you go back to this case, I basically use a linear stapler of a 60mm length, and I will close the intraotomy by another 60mm linear stapler. Now, if you can see this clip, this is a clip that has been placed tangentially at the staple line. And the advice that I've learned from this case, and what I would advise you to do, is that never use the clip in perpendicular to the staple line. You have to use it horizontally. But also at this site, particular site of any Roux-en-Y gastric bypass with the jejunostomy, it has been reported by several surgeons that sometimes they have obstruction by a blood clot. This is something that happens rarely after a Roux-en-Y gastric bypass, but it has been reported so many times in the literature. And I think about 12 years ago, I have presented the first poster about having a JJ intersusception. But I have taken this nicer pictures from an obesity surgery paper in 2009, where there is a jejunal intersusception. And this is why we started thinking about how we can stop it, either by tailoring the JJ size or by how to fix the biliary limb end, the blind end of the biliary limb. And this is how a lot of surgeons would do, because the technique of doing a jejunostomy can be the triple technique, which has been advocated for quite a while, by using a 45 on this direction and then another 45 in this direction, and then closure of the intraotomy either by stitching or by another staple. But what has been recently been advised to most of the surgeons who are common Roux-en-Y gastric bypass performance is to try to incorporate the blind end of the biliary limb into the bursa string stitch that closes the JJ defect. It has been reported that by using interrupted suturing of the JJ defect with further weight loss and loss of the muscle of the fat bulk of the mesentery, then the holes will become bigger. And we have seen a lot of cases which had internal herniation, although that in the original operative notes it has been reported that the defect has been closed. So I would suggest that if when we close the JJ defect, it needs to be like a bursa string, and this is how we can almost prevent having an internal herniation. Now, one other issue while doing a Roux-en-Y gastric bypass is to think about any synchronous ventral herniations. And this is quite common in our bariatric patients. So the debate here will be to do a synchronous versus delayed repair. And if we're going to do repair the hernia, shall we do it totally laparoscopic or through a hybrid approach, which I have been practicing lately? So I think the wider the wise way of thinking about internal herniation is, number one, to try to think about how big the defect is. So if the defect is big, and if a hernia will just go in and go out without the possibility of having any further bowel obstruction, then I think it's better to leave it alone, carry on with the Rowan Y gastric bypass, and repair the hernia later. If the hernia neck has been blocked by a small bit of omentum, then I think we should leave the omentum blocking the hernial sac, and this is how we can somehow safeguard having another reconsideration of another potential hernia that can happen after a Rowan Y gastric bypass. If the hernial defect is small enough that it can be controlled safely by either having a laparoscopic or a hybrid repair, I don't think it's a bad idea to try to attempt that, but it needs to be secure enough to prevent any dismantling of any of the stitches that will be taken to fix the hernia, or to make any mesh that we're going to use in repairing the hernia that will make this patient vulnerable to a recurrence immediately after having the Rowan Y gastric bypass. Now, the last case is having some GI malfunction because of the anastomosis, and in this slide, I've got some cases that has had some stricture at the gastrojejunostomy, and this one is a circular stapler, and this is after the dilatation. This one is a patient who had a fully hand-sewn gastrojejunostomy, and this is what I meant by saying at the beginning of my presentation that sometimes if you use non-absorbable suture, they can present like having a mesh at the gastrojejunostomy side, and this needs to be taken endoscopically. And finally, obviously, we all have seen some anastomotic ulceration, which can lead to edema and some form of obstruction. Now, we can also have some pouch obstruction either by a foot bolus or by a bezoar, and it all has been reported again. Now, we should not forget that there are the other general causes of having a bowel obstruction after a Rowan Y gastric bypass. We shouldn't forget the tumor factor or cancers that can happen in our bariatric patients, because we know that there are lots of GI cancers that are known to have a higher prevalence in bariatric patients. And we also should not forget the usual post-Rowan Y gastric bypass constipation, which can present in the form of a subacute obstruction. If we think about the literature, there has been few publications that has been up with decent numbers to talk about the Rowan Y gastric bypass, and this is one that has been published in Surgical Endoscopy in 2014, a decent number, 2,395. It has reported small bowel obstruction in 3.9% of the cases. 50% of them were due to adhesion, 20% due to internal herniation, and 10% due to intussusception. This is another one in the Journal of the Society of Laparoscopic and Robotic Surgery. Smaller number, 249, 6% incidence, 70% of the 15 cases of obstruction were adhesive, and 37% were due to internal herniation. And if we talk about internal herniation, then I need to point out that according to the literature and according to my personal experience, that they are most commonly to happen at the JJ rather than the Peterson. The problem with small bowel obstruction after a Rowan Y gastric bypass is that we have got a different management. So to start with, patients do not usually come and present with vomiting. The most common presentation is vague abdominal pain. Second thing is that we cannot apply the second drip rule for any small bowel or any bowel obstruction that we get in the general surgery emergency care. Now, the other story is that we are racing against time, because if we're suspecting an internal herniation, then we have to make sure that we're not missing this window before the bowel starts to become ischemic. And our best measure for that is to just keep an eye on the lactate. Another point is whether we need a specialist bariatric unit to treat with this patient, or this can be dealt with by a general surgeon. Obviously, it would be much, much better for these patients to be dealt by a specialist bariatric surgeon. But if not, then you shouldn't forget that this is a bowel obstruction, and this can be dealt with by a general surgeon who has got a basic understanding of what do we do in bariatric surgery. And the final issue is lab versus open. In most of the cases, we manage our bariatric patients either presenting with acute symptoms or for elective surgery through lab, but sometimes we have to revert to open if conditions are unfavorable. So the messages here after this presentation is that we think we need to think bypass, always bypass, when we are faced with someone who's coming with what looks like a bowel obstruction. We should not forget that bowel obstruction in bariatric surgery should mean vomiting, because that's not a common thing. We usually see our patients in clinic rather than coming to A&E. We need always to remember that there is some electrolyte, trace element, and vitamin deficiencies in the background that could be the reason behind this bowel obstruction. We should not forget that our biggest fear is the mesenteric defect with the internal herniation. And in this case, we have always to think, when are we going to take this patient for a diagnostic laparoscopy? And if we are missing the window before the bowel becomes ischemic. And one important sign for that is that once the patient's pain starts to go away completely, it doesn't always mean that the patient obstruction or that bit of bowel that has herniated has come back to its original site. It can also mean that this bit of bowel has died and started and has stopped sending signals to our body and present with pain. Don't forget that we sometimes get constipation, and always apply the general surgery rules. Thank you very much.
Thank you, Dr. Mohammed, for this nice presentation. We have some questions for you. The first one, do you recommend to close all the port side after your operation or not?
Right, this is a very good question. Can I talk, or is there someone talking about that? Can you hear me?
1 second, please. Okay.
Yeah, Dr. Tariq, the usual practice is that if we're going to use a muscle splitting port, then in most of the cases there is no need to close the 10-12 millimeter ports. My practice is that if I use anything larger than 12 millimeter ports, then I usually use an endoclose to close them. And because I am a regular user of the circular stapler, which needs for the left 12 millimeter port to be at least stretched to allow the circular stapler to go into the abdomen, then I usually, yes, close this one. But I don't routinely close the right 12 millimeter port.
Another question, in your first case, did you release the stitch endoscopy, or you need to open the patient?
The patient who has got the, no, the first patient who had an obstruction at the gastrojejunostomy?
Yes.
No, that was done completely laparoscopically, because what we've done, we went in and we have taken the stitch, and then we have passed a large orogastric tube, and we've tested again for the patency of the anesthesia.
And you can't do it by endoscopy?
No, we haven't tried, to be honest, to Dr. Tariq, but I thought that it would have been difficult because of the edema of the wall. We haven't tried, but I thought it would have been difficult.
Another question about what is the best radiological modality to diagnose internal hernia after root gastric bypass?
Very good question. As we both understand that using a CT with oral and IV contrast can give you some good results and some good diagnosis of internal hernia, but at least it will give you no signal in 20% of the cases. And I think the best modality is that if there is a suspicion, diagnostic laparoscopy would be your best friend.
Yes, good. About your jejunal anastomosis, do you use 45 stapler or in both direction, or use 60, or use only 45, and why?
Yeah. When we started doing bariatric surgery, we used to do the 3 staples technique. So 45 in both directions, and then close the defect with another 45 or 60. And this is when we had this case of intussusception. And we thought that actually having a 9 centimeter jejunostomy is not needed at all, because basically we're draining the bile. We're not draining any active food boluses coming through that side. This is when we have started shifting, going to the only 160, and then closure of the introtomy is either by having a vicryl stitch or by using another linear stapler to close it.
Is another question, last question about in a patient with NASH,
Yes.
fatty liver.
Yes.
What's the length of your biliary and military limb? You make change in your practice as regards the condition of the patient, especially with NASH?
NASH.
Yeah.
To be honest, Dr. Tariq, no, we don't do anything. But our practice has always been an 80 centimeter biliary and 120 centimeters of rolling. Recently, in the last probably 3 or 4 years, because we have started to see patients recurring with some weight regain after Roux and wide gastric bypass, we have reverted the equation. So we're more using 120 of a biliary and then something between 80 and 100 of a rolling. Talking specifically about NASH patient, we have not changed any of our practice because the early results or the kind of number of cases that we have done for NASH, we have seen no changes in either their nutritional status after gastric bypass, but we have seen the same improvement of their NASH condition.
Okay, thank you, Professor Qalawi. And now we will shift for Dr. Abou Wahed, who will modulate the next session. So please, Dr. Abou Wahed.
Thank you, Dr. Tariq. Thank you, Dr. Qalawi, for the presentation. Our next presentation will be about nutritional deficiency after bariatric surgery. It's going to be presented by our dietitian, Fatma Rodiari. Madam Fatma, go ahead. The mic is with you now.
Hi, everyone.
Yes, hello. Yes, very good.
Fine. So, my presentation will be about what happened after the bariatric surgery, what kind of deficiency that will happen with the patient. So just give me a minute to open my presentation, please, and we will resume. So let's start.
Yes, very good.
So what happened after bariatric surgery are most of them will be like deficiencies like micronutrient. The main one will be protein. Micronutrients like vitamin, minerals will be like water soluble and fat soluble vitamins. We'll talk about also mineral. Lastly, the fluid. So first of all, we all know that obesity is already a risk factor for malnutrition for micro and macronutrients. So all patients have to be screened prior to any bariatric surgery. And although those deficiencies can be also prevented by screening, because we have to know that all these deficiencies has to be like at least taken care of before they even start the bariatric surgery itself. So regarding the deficiency, it comes in 2 ways. So the patient either will have a restrictive quantity of food. This will go with the restrictive procedure like sleeves, bariatric palliation, or like band. Other will be like interrupting the digestive process, will be like malabsorption, like what happened with the gastric bypass or mini gastric bypass, or even biliopancreatic diversion. So these main things will happen, either restricting or interrupting with the digestion process. So we'll start with the protein. Protein malnutrition will happen with most of the patient. Like I can see like most of my patient will have like after 3 months, they will have like their albumin will be very low. Their protein intake also will be very low. They will only concern about vegetable and fruit. They will forget the protein. So I go with them that
We don't have voice, but man, just check your mic.
We lost the voice.
Yeah, check your mic again. See the connection is correct. No, it is still not that much, not clear. Still, maybe the internet connection is not that much strong.
Excuse me for a minute. Let's see what's happened.
You can hear us or no?
Yes, I can hear you.
Yeah, now it's okay. Go ahead.
It's okay now?
Yeah.
Oh, it's okay. I think maybe the internet, as you said, yeah.
Yeah.
And protein malnutrition in the patient can be categorized by decreased hepatic albumin, that, as I told you before, muscle wasting. Most of them, they will have weakness, alopecia, which is known as spot baldness. So let's go to the next one. So also protein malnutrition is associated with anemia, iron, B12 deficiency, folate, copper, and even the deficiency of zinc, thiamine, and B6. Some of the patient also will come with electrolyte imbalances, mineral disturbances will happen, low immunity they will have. It also will result with decreased so, and the preserved fat will be like increasing. So it will be all will based on their food intake. So I will know what kind of thing that they're eating. So they will not eat protein, they will go to another stuff. And they will also have failure to lose their weight or regain after each session when I see them. So this is how I can check them. So what is the recommendation of protein that we have? The baseline will be like 1 gram per kg or 1.5 per kg. I will take the average for most of the patient. But if the patient had, let's say like they have complication after the surgery, I will go with 1.5 to 2 kg per ideal body weight. This will be like based on the serving of protein that I will have for them, almost like 8 servings of protein plus let's go with whey protein or like protein supplement that I will give them. At least they will reach 60 to 90 gram of protein per day. So they have to reach minimum of 60 gram or maximum of 90 gram protein, sometimes 120 gram protein per day. So I will emphasize with the patient mostly. So to check that the protein should be in protein will be in two kinds. High protein food, which is based on animal-based protein, which is egg, meat, elk, milk product, cheese, sometimes labna, and also plant-based. So they don't know that protein also it's based also on plants. So protein-based plant will be like edamame, lentil, beans, oats, quinoa, and etc. So they have to know that protein comes first in their pyramid. So they have to go first with their supplementation, protein, and then they have to eat vegetable, fruits, and also grains. Protein came first in everything for them. Supplementation with whey protein powder or like whey isolate, like in milk and other product, they can take it for sure, but I have to count for them like how much protein they will take, and then it has to be added for them. As I told you before, it has to be like 60 to 90 gram based on the patient requirement and the intake that he is taking every day. So we'll go with the micronutrient now. The first micronutrient will go with the water-soluble vitamins, vitamin B12. The etiology of the vitamin B12 deficiency, it's because of the inadequate contact with intrinsic factor, decrease the risk of gastric acid, and low intake of food that address vitamin B12 and folate. We have to know that these two supplementation is important in preventing elevated levels of homocysteine, which is directly linked to cardiovascular events such as myocardial infarction. Vitamin B12 deficiency can occur following gastric bypass procedure, mostly in most of the patients, which also contribute to anemia for them. To continue, the food source of vitamin B12 in animal base is like mostly will be like fish, red meat, chicken, liver, egg, cheese, let's say clams. Plant-based one will be like fortified cereals, almond, nutritional yeast, which I show them. They don't know what is nutritional yeast, but I always show them like a picture. At least they will know they have like other options to check. let's say fortified oat, rice, fortified tofu also, which is a plant-based one. They have to know that these are the possibility that they can take protein from them. The supplementation for the vitamin B12, the DRI, the daily requirements intake for them should be like 2.4 microgram per day, or otherwise they have like complication, of course it will be much greater than this. To continue, thiamine, which is B1, the etiology behind the thiamine deficiencies is up because the thiamine is absorbed mainly in the duodenum. What's happened is that due to the participation of thiamine in carbohydrate metabolism, high dietary intake of carbohydrate or administration of glucose could participate in clinical symptoms in patients with low reserve of thiamine. So it can occur in a result of what? Frequent episode of vomiting, reduction in acid production by gastric pouch, restriction of food intake that most of the patient that will have. So the food sources will be fish, like trout, will be high source of thiamine, sunflower seed, flaxseed, egg, whole wheat, lean meat, cereals, and cauliflower, like vegetables, and also like meat ones. So the DRI for them and the upper limit is 1.1 to 1.2 milligram per day for female versus male, and there is no upper limit for thiamine intake. To continue now, the third one is folate. The etiology behind the folate is the same as the vitamin B12. So most of them will have an inadequate diet, less digestion time in the stomach. Bypassed intestine and some of the procedure, inadequate stomach secretion. So what are the source of folate? The same as vitamin B12, they are mostly the same. So leafy vegetable, broccoli, spinach, Brussels sprout, peas, lentil, and beans, fortified bread and cereals, chicken liver, beef liver, and etc. So of course there is many options, so I have to limit most of the options that I have. So the DRI for folate will be and the upper limit. The DRI is 400 gram per day, and the upper limit is 1,000 gram per day for the folate. So we'll continue with the fat-soluble vitamins, as we called as dietitian as DCA. First of all, we'll talk about vitamin D and calcium. The etiology behind the vitamin D and calcium is the duodenum and the proximal jejunum are the main site of absorption of calcium by passive diffusion, and on the other hand, by effect of vitamin D. So if there is no vitamin D enough, it will happen, deficiency will happen eventually. Calcium deficiency are most often result in intolerance of the patient to some of the product like calcium, like milk and milk product that they have. But it's also a result of a short circuit of the duodenum and the gastric bypass procedure. Also rapid weight loss and absorption change that occurs post-operatively at any time after 8 weeks of surgery, which most of them will have like calcium and vitamin D appear the first day. So vitamin D sources we will have in milk and milk product, egg, fish, fortified food, cereals, fortified bread and grains. And the calcium will have milk, soy milk, cheese, beans, almond, green peas, and broccoli, fortified bread and cereals. So the DRI and upper limit will be 5 microgram for adults and 10 microgram for adult like ages from 50 to 70s, elderly ages 50 to 70, and 15 microgram per day for ages greater than 70s. And the upper limit for the vitamin D will be 50 microgram per day. And this is the end of vitamin D and the calcium. So we'll continue with vitamin A deficiency. The etiology behind the vitamin A deficiency is most of the bariatric patients are already at risk of vitamin A deficiency, particularly after like bibliopancreatic procedure, due to limited absorption area, fat malabsorption, and also bacterial growth. So the DRI for vitamin A and the upper limit, we can say that DRI is 700 gram per day for female and 900 gram per day for male. And the upper limit for both will be 3,000 milligram per day. Food sources for vitamin A will have in liver, dairy products, fish, let's say dark colored fruits and leafy vegetables. We'll continue with vitamin E and K. So vitamin E, the absorption of vitamin E and K occurs mainly in the jejunum and ileum. So you can see most of the deficiency comes with the bypass patient. Most of them will be like that. So I have to be careful with them in these deficiencies. So the food sources for vitamin E will be vegetable oil, unprocessed cereals, grains, nuts, fruits, vegetables, and meats. The DRI for them and the upper limit. So the DRI is 50 milligram per day, and the upper limit will be 1,000 milligram per day. Vitamin K food sources will be in green vegetables, Brussels sprout, cabbage, plants oil, and margarine. So the DRI for vitamin K is 90 grams per day for females and 120 grams per day for males. And the upper limit for both these, for both female and males for vitamin K is not determined. We have also a couple of mineral deficiency that we have. So first of all, iron. The deficiency occurs due to anatomic changes after surgery, a low tolerance for red meat, reduced acidity in the stomach, the chronic use of some drugs to suppress the secretion of the gastric acid. So the food source for the iron will be meat, fish, poultry, eggs, and rich grains, dried fruit, and some vegetables and legumes. So the DRI for them will be 8 milligram per day for men and 80 milligram per day for women, ages between 19 to 50 years, and the upper limit for both will be 45 milligram per day. So also copper, they comes with a copper deficiency. Some of them will have like their own, let's say their own assessment that they're taken, like not even by our hospital, like sometimes outside. They will have like the full things because I require them sometimes to just to check a couple of minerals sometimes just to be sure that they don't have other like deficiency that we're not know about. So the etiology about the copper is an increased risk of copper deficiency appears after the malabsorption procedure, as well in case of persistent diarrhea in some of the patient. So routine monitoring is not recommended, and concentration should be elevated only in patients with the unexplained anemia, neutropenia, myelonephropathy, or impaired wound healing. So the food sources of copper will be leafy green vegetables, liver, oyster, spirulina, shiitake mushroom, nuts and seed, dark chocolate, and lobster. So how to prevent the copper deficiency? It's only about supplementation, which contain 2 milligram of copper per day, or otherwise the food sources that I will apply for them and their meal plan for sure. So also we have the zinc deficiency sometimes. So it's unknown how the etiology comes, but the routine testing for zinc deficiency should be performed after the malabsorption procedure. So the food sources for zinc will be meat, liver, egg, oyster, peanuts, and whole grain. The DRI will be 8 milligram per day for females and 11 milligram per day for males. And the upper limit for both of them will be 40 milligram per day. And the last one also for sure, the fluid requirements. Most of them also will come, the two things that I will have like appear in most of my session with them, they will have protein deficiency, or like protein intake will be very low, or the fluid intake will be very low. So we'll come with dehydration. So mostly the most dangerous things, nutritional risk immediately after the protein will be like fluid dehydration. So it's challenging to most of the patients that I have because they don't like the taste of them. They don't like the taste of the water, most of them. So it will be very challenging also to have the 7 cups or how many liters that I will give them. So it will be challenging to most of the patients, but for sure after each session will be much better than the other. So what is the guideline for fluid requirement? First of all, they have to avoid consuming liquid with meals itself. So at least they have to take like 30 minutes after a meal to ingest the fluid, or they have to take it before the meal, at least 30 to 1 hour. So what I said to them, we have to leave 1 hour for foods, and then the second hour has to be for fluids. They have to remind themselves about that. So the fluid goal for them will be 1.5 liter or 2 liter of fluid. If they can do more, it will be much better for them also. So they have to stop eating and drink while they are feeling the full feeling that occurs for them. So they have to avoid carbonated beverages like Pepsi and most of the stuff, regular soft drinks, sizzling water, because they may be associated with weight regain that they will never know about. But because I know about these things, so I have to like remind them that please be careful, don't take these kind of stuff. So the home message that I have for you all, that all bariatric procedure, for sure, they will have significant potential for producing long-term nutritional problems, but it can be prevented by supplementation. It requires long life compliance with the supplement for the patients, minimizing by regular routine and monitoring. So they have to check on them on a regular basis if they have deficiency. So this is the last slide that I have.
Thank you very much, Fatma, for this nice presentation. You make us very hungry through this fruitful slides, and also hungry to ask you so many questions. So Dr. Tariq, if you don't mind to take over the chat box and see how many questions are there. I feel there are a lot of questions here. Dr. Tariq.
Yeah, you can continue to trouble this.
Okay, let's go. Yeah, you go through the question, Dr. Tariq. Just see what you can see, because, yeah.
Okay, first, if you have patient, Fatma, for a high uric acid and child B hepatic disease, what can you do when you are prescribed for home protein? Because you know protein at this time will increase the uric acid, and the hepatic patient usually we have withdrawal of some protein. What is your option or opinion about how to deal with this patient?
My option for them, because we are concerned of the uric acid, I will for sure I will give them protein, but I have to make sure that they will take the least uric acid food sources. So they have to make sure that I will give them a list. So what kind of high uric acid food there is and what kind of low uric acid there is in food. So they have to minimize their intake only to take the low uric acid food. And then I have to check with them like after like 2 weeks when they come back, or like 1 month, to check how much is the uric acid for them. And if it was very also high, we'll minimize some of the animal-based one. So we'll go with the plant-based protein just to avoid the high uric in their assessment when I check with them.
Another question, do you recommend high protein diet for all bariatric surgery patient? And if your patient has sleeve, patient have bypass, it's the same, you must receive high protein diet?
Yeah, for sure, because what I see in most of my session with the patient, they will forget the protein. I don't know how, but they will forget the protein. So every time we have to check the albumin and the albumin serum with them, because most of them, they will go with the leafy vegetable. Fruit will be easier for them. They will think that it's very heavy to take the protein. So on all patients, sleeve or bypass or anything, protein should be the main thing post-bariatric surgery for any kind of procedure for them. Yes, it will be the base for the pyramid.
From your experience, do you think our patients have good educational supplement about nutrition before and after surgery, or usually our patient has sufficient in this field?
Well, not all the patients, they have a sufficient information. So that's why sometimes I require them at least to come, not even like 2 visits, 3 to 4 visits at least, to know what will happen after the surgery, because everything begins after the surgery itself. So they have to know everything before the surgery, what kind of deficiency, what kind of food that they have to take, how much is the limit for them. So not all of them will come with the sufficient information that they need. So we need to have more session with them, for them at least to know what kind of food that they will take after the surgery. So no, I don't think that they have enough information, and most of the patients that I have at least.
Last question about, we have problem with our patient with 2 food and 1 drink. Water, a lot of patient complaining he can't drink water, and at the same time the rice and red meat. What is your recommendation about this problem?
Okay, first of all, the water for sure, because some of the water for them will be like heavy. So I will recommend them to at least try several water. So some of the water are a little bit lighter than the others. Some of them, they will not like the taste, so they have to add like strawberries, anything with a taste like lemon, mint, something that it will like the taste will be much better for them regarding the fluid. So the other one, well, I didn't
rice and red meat.
Okay, rice and red meat. Some of them, they will have like a problem with rice because rice sometimes can be bulk, can cause a bulk in the stomach. So it will be very hard for them to consume it. So I will tell them, don't worry, you have the other choice for carbs, so don't worry about that. They will go with the bread and other stuff. Red meat, it's the same thing. They will feel like pain in the stomach, even if it was like small amount, because meat mainly because the stomach needs to be to digest the meat very hard in a very like constructive way. So it will be very hard for them to at least to digest the meat. So I will tell them like red meat especially, but poultry and the other stuff like protein, it will be very easy for them. So they have to know that they have other options. It's not about only red meat.
Okay, thank you, Dr. Fatma, for
one question for Fatma, because somebody is asking here. What do you think? For how long should we continue with the replacement of the supplement for the patient? Can we lifelong, you think, or it can be replaced by the type of the food later on?
Well, in my opinion, most of the patients that I saw, at least they need a 1 year, because even after 6 months, if I go back with them, they will have some of the food sources will be really, really low. Even if I emphasize in some of the food that they have to take like a protein-based food, they will eliminate it in most of their diet. So at least a 1 year it can be there. After that, I think most of the patients, they will manage with their dietary intake again. So they will be much better.
Now you are talking about the sleep patient or those with the bypass?
Mostly bypass. Mostly bypass. Sleep patient, some of them are like, okay, after at least 8 months. I will check like after 8 months, most of them will be fine, but bypass for sure at least 1 year for them to check at least if they are taking the full requirement, at least 60 to 90 grams. So you have to assess them. If they are okay, I will let them.
I think Professor Safwan have one question. Can you please?
Yeah, I've been raising my hand for 10 minutes.
Sorry.
Actually, thank you. No, still, I'm joking. Actually, it's not a question.
We have a problem with the connection.
It's not a question, actually. First of all, I'd just like to, Dr. Fatma, thank you very much for this excellent presentation. And I'm a bit greedy. If you might be generous to send it to us, it is really very helpful.
Inshallah, for sure.
One comment I have, actually, Dr. Tariq, thank you for raising the issue of the water difficulty with the sleep patients. I couldn't find it anywhere, actually, and my patients, I would say up to 35% complain of difficulty in swallowing water, but not juices and not milk and not. But then listening to the feedback, I just wanted to share you one thing, and I found it to be true. A few patients told me that the best waters that they can drink easily, but not the others, are 2 brands. One of them is called Serma, Turkish water, SERMA, and the other one is called Aquapana, not Aquafina. They are both cheap and available even in petrol stations.
No advertisement, please.
Really, and when I started telling the patients who were complaining of water, by the way, the worst one with my patients is Al-Ain. They just hate it. Okay. So when patients ask about why can't we drink water, and I tell them about Serma and Aquapana, the vast majority, by far, they tolerate it well, and especially Serma. Just sharing information.
Yes, yeah, I agree with you. Yes.
Thank you.
Okay, thank you. Okay, Dr. Abu Wahid.
Okay, thank you. Thank you again, Fatma. Thank you, Dr. Safwan, for this Hussam Abu Sahmin.
Yeah, problem. I think there is a problem with connection with Dr. Abu Wahid. So I would like to invite Dr. Hussam Abu Sahmin to start his presentation about the drug map, how to deal with type 2 diabetes. This for surgeon, not for medical people. So please, Dr. Hussam. Please, Dr. Hussam.
So I was disconnected, sorry for that. So our next speaker will be our consultant endocrinologist, Professor Hussam. He's going to speak about drug map and using which drug medication can we use in hypoglycemia. Professor Hussam, please, the mic with you.
Yeah, Dr. Abdulwahid, I'm just struggling to get to access my presentation. So
you have, I mean, you open already your presentation, right?
Yeah, let me just.
Yeah, you have you look at the screen down. There's share screen. Just press on it, then will come some option.
No, first open it in your desktop.
Okay.
Then
Open
after that, make share screen.
Okay.
You have your presentation now in front of you?
Yes.
Okay, now there's something down called share screen. In the down, just go down with your scroll down, you will see something coming.
Yes.
Yeah, share screen, press there. Yes, very good. Now it's coming. It will appear now. Okay, go ahead. Now you can, yes, you have now the mic and you have the presentation. We are seeing you.
Okay. Good evening, everyone. Thank you, Dr. Tariq, to give me this opportunity to talk about diabetes. I know, as you said, most of the audience are surgeon, so I will do my best to simplify the presentation. So as Dr. Abdulwahid said, my name is Dr. Hussam Abu Sahmin. I'm a consultant in endocrinology currently in Al-Qasimi Hospital. So, okay, so the outlines, we'll talk briefly about the background, pathophysiology of type 2 diabetes, modalities of therapy, and then the latest European and American guidelines about treatment of type 2 diabetes, and then I will conclude. So we'll start with the background, the definition of diabetes. Obviously, diabetes is not a disease, it's a syndrome, it's a group of metabolic disease characterized by hyperglycemia. So basically, it's either deficiency in the insulin secretion or the insulin action or both. So how you diagnose diabetes? So we've got some investigation. It's either a fasting blood glucose more or equal than 126 or 7, or a part of oral glucose tolerance test, 2 hours or a random blood glucose of more than 200 or 11.1, or an HbA1c more or equal to 6.5, or lastly, if someone's got symptoms of hyperglycemia or osmotic symptoms, which is weight loss, polyuria, polydipsia, and the random glucose of more than 200. This is what we defined diabetes. So obviously we know about types of diabetes. We've got type 1, type 2, gestational diabetes, and others. According to the International Federation of Diabetes Atlas 2017, as you could see here, this is our region here, the Middle East and North Africa. And according to 2017, there were about 39 million patients with diabetes, and this number will increase dramatically to 82 millions by 2045. We're talking about an increment more than 110%, and this is an issue is worldwide, as you could see here. By 2017, it was around 425 million patients with diabetes, and this number will increase to 629 by 2045, which is nearly 50% increment. So why is that? Because we're talking about obesity. There's a close link between obesity and type 2 diabetes, as these studies showed clearly. As your BMI goes up, the relative risk of diabetes will go up. At the time of diagnosis, most of the patients, they will have a BMI around 30. And there's another study here which goes with the previous study. As you can see here, the line goes up with the relative risk of the type 2 diabetes goes up as your BMI goes up. But the interesting bit in this study, as you can see here, the line is more prominent with the female than the male. So, for example, if you're a female and your BMI around 35, your relative risk of developing type 2 diabetes is around 50%, which is quite a dramatic one. So, unfortunately, more than 90% of people with type 2 diabetes that are overweight or obese, i.e. BMI above 26. So why are you concerned about diabetes? We mainly are concerned about the complication. We talk about microvascular complication or macrovascular complication. In microvascular, we've got retinopathy, nephropathy, and neuropathy. While the microvascular, we're talking about stroke, TIA, myocardial infarction, ischemic heart disease, heart failure, and lastly, peripheral vascular disease. Unfortunately, at the diagnosis of type 2 diabetes, this is at the diagnosis. So we're talking about nearly 21%, they have got some evidence of retinopathy. We're talking about 18% of nephropathy and 35% of hypertension. So this is just at the time of diagnosis. This is quite scary percentage. So pathophysiology. So if I ask a medical student what's pathophysiology of type 2 diabetes, he will tell me that it's a deficiency of insulin, or the insulin doesn't work well. And this is not quite true at our time being. So as the Professor De Franzos nicely proposed, a pathophysiology at 8 causes cause type 2 diabetes. They call it omnious octet. So we'll talk, he suggests that there's a decrease of insulin secretion from beta cells of the pancreas. There's also increase of hepatic glucose production from the liver. There's a reduction of glucose uptake from the muscles. And also the alpha cells in pancreas producing more glucagon. And as we all know, there's an increase in incretin effect and an increase, decrease of there's a decrease in incretin effect and decrease of incretin secretion. And also there will be more stimulation of lipolysis, which will cause free fatty acid to accumulate more in the system and will help in insulin resistance. And also there's an increase of glucose reabsorption from the kidney. And finally, the neurotransmitter dysfunction, mainly because of the incretin effect. As you would know, most of the patients of type 2 diabetes, they feel hungry most of the time, and this is due to these issues. So what kind of therapy that we've got available? So we'll talk about the most common use in type 2 diabetes is metformin. As we would know, it's derived from the French dialect, act mainly on the activate of AMP activated protein kinase, mainly in the liver or on the muscle. And by activating this, will cause reduction of the hepatic glucose production, and also will help the muscle to improve the peripheral glucose uptake. And also they have got a modest effect on the lipid metabolism as well, in terms of reduction of triglyceride and LDL. And finally, they've got the role in delay intestinal glucose absorption as well. What's the advantage and disadvantage of metformin? So we all know that metformin normally is weight neutral, but in a lot of patients, that could cause a slight weight reduction. It doesn't cause hypoglycemia normally, and it's cheap. Unfortunately, some patients that cannot tolerate it because of the GI upset in form of diarrhea and vomiting and nausea. And obviously, we need to adjust the dose of metformin according to kidney function. We should have the dose if the AGFR less than 45 and stop it completely if the AGFR less than 30. The second thing is sulfonylureas. We normally use glycoside here. So just quickly, I will tell you how the insulin being secreted from the beta cells in the pancreas. So as you can see here, glucose get inside the cell from the GLUT2 glucose transport receptor, and that's lead a lot of cascade ending up with the ATP, which is close the potassium ATP channels. As the result of closing of that, this cell membrane will depolarize, and then leading to coming the calcium cells inside the cells, and the calcium will have the insulin to be secreted. So how the sulfonylureas works? It works in here, and potassium ATPase channel will block that. As a blocking that, so will help calcium to get in and insulin to be secreted. As simple as that. So what's the advantage of sulfonylureas? It's very cheap and it's very effective. So it's a second after the insulin in terms of reduction of the glucose and reduction HbA1c. However, will cause a lot of hypoglycemia and also weight gain. And there's a lot of patients we cannot use it, especially in elderly people. What about the other group of anti-diabetic medication, thiazidinones or TZDs? The only medication available is biglutazone. It works on this receptor, peroxisome proliferative activator receptor gamma, which available in the liver and adipose tissue and muscles. By activating this receptor, will increase the hepatic glucose uptake from the muscles and adipose tissue, will reduce the hepatic glucose production from the liver. So in summary, will increase the insulin utilization, glucose utilization from the body, and reduce the glucose production. What's the advantage of biglutazone? It doesn't cause hypoglycemia, safe for renal failure, and is cheap. Unfortunately, we cannot use it because it causes weight gain, because of peripheral edema, and sometimes it can cause anemia. And there's some studies linked biglutazone with the fracture of the wrist in the female. It's completely contraindicated in patient with heart failure. The other modality, which is incretin-based therapy, I think you are familiar with this medication because it's linked with bariatric and obesity. So the food will activate hormones, which are mainly GLP-1 called incretin, and these hormones, the half-life of these hormones is very, very short because of the enzyme we did it before. So if inhibit these hormones, which this is the group of medication called DDP4 inhibitors, will improve the GLP-1, our native GLP-1, and the function of GLP-1 here, as you could see, will work in the brain, reduce the appetite, works in the stomach, reduce the gastric emptying, increase the insulin synthesis and beta cell proliferation, and beta cell apoptosis reduces from the pancreas, and also reduce the glucose from the liver. So we've got a lot of effect. The advantage, as I said, DDP4, the weight neutral, GLP-1 receptor agonist, they cause weight loss, that doesn't cause hypoglycemia, and they've got cardiovascular protection. The side effect, they've got the GI upset in forms of nausea and vomiting, and DDP4 can cause mild cystitis or pharyngitis. We cannot prescribe this kind of medication in people with pancreatitis or thyroid medullary carcinoma or thyroid cancer. The last group of medication, which is SGLT2 inhibitor. So this is a cartoon of denephrine. As you would know, everything gets filtered in the kidneys, get reabsorbed back, especially, and this is including the glucose. In the proximal convoluted tubules, you have got this receptor, which we call it SGLT2 receptors, which is responsible about reabsorbing about 90% of the glucose back to the system, and the last 10% of the glucose get reabsorbed in the tube of Henle by SGLT2/1. So what happens if you block these receptors? So you prevent reabsorption of about 90% of the glucose, which is good for the patient because you will have less glucose in the system, and as losing glucose, you lose calorie, you lose weight. And this is the advantage of these groups of medication. So it will cause weight loss, which is good in our patient, and doesn't cause hypoglycemia because it works in completely different manner than the pancreas and the insulin, and it's got cardiovascular protection, and obviously it's beneficial for people with heart failure. The disadvantage of this medication, as you're excreting sugar, so there's a good media for developing UTI and genital tract infection, and especially in females. we've got the limits in terms of kidney function, as the medication primarily works on the kidney. So if you've got low eGFR, the medication would not work in a proper way. So if you go back to octate omnium that I mentioned early on, so this is, we need to target our medication according to the pathology. So if you'd like to increase the insulin secretion, we've got sulfonylureas, we've got GLP-1 receptor agonists, we've got DDP4. If you'd like to reduce the glucagon secretion, we've got GLP-1 receptors, we've got DDP4 inhibitors. How about if you would like to reduce the hepatic production of the glucose? So you've got metformin, you've got TZDs. And here, and we've got only GLP-1. So if you would like to increase the glucose uptake, you've got metformin and biglutazone. In here, reduction glucose absorption is only SGLT2 inhibitors. So in here, we've got biglutazone, reduce the lipolysis, reduce the free fatty acid in the system. And finally, if you'd like to increase the incretin effect, we use either GLP-1 receptor and DDP4. As you could see, when you treat people with type 2 diabetes, you need to tackle with different mechanism, so you will have better effect in total. So this is just briefly, this is the not the latest guidelines, but this is the one before. But the guideline is not that different. So this is 2018 European and American guidelines of type 2 diabetes. It's a busy slide, but just I will summarize it. So the first line of therapy, we all agreed that we need to use metformin plus lifestyle, which is losing weight management. We don't start with just life management and see the patient after 6 months. This is not true anymore. So we need to give metformin and alongside the physical activity. And we need to see the patient more often. It's 3 months interval, not about 6 months. But the things that has changed now, you need to ask yourself, is the patient in front of you, he's got either he's got atherosclerotic cardiovascular disease, or he's got CKD. So what do you mean by atherosclerotic cardiovascular disease? Is the patient's got coronary artery disease, he's got MI or stroke or peripheral vascular disease or heart failure? If the answer is yes, regardless, you need to use, alongside metformin and lifestyle, you need to use a GLP-1 receptor agonist with a proven cardiovascular benefit. You've got here liraglutide or dulaglutide or semaglutide, with or by itself with an SGLT2 inhibitors. So this is the new strategy. So we cannot just use any other medication if patient has got an established cardiovascular disease. So if the patient has got heart failure or cardiovascular or CKD, is the same thing. But in heart failure, the SGLT2 inhibitor, which showed an improvement if heart failure, is dapagliflozin, not empagliflozin. So we need to use dapagliflozin. And the same thing we need to use in any GLP-1. So this is the different thinking about treating people with type 2 diabetes. So let's say if the patient hasn't got any cardiovascular risk or CKD. So here, the stage is open, but you need to ask yourself 3 questions. The first one, does the patient, we need to minimize the hypoglycemia for the patient. We're talking about maybe elderly people. We're talking about people who drive for living, like lorries. We're talking about people who works in heights. So the hypoglycemia is quite dangerous. Or if the patient is obese, or we'd like to reduce the patient weight, or the last thing is the patient can afford the medication or not. So we need to ask ourselves 3 questions if in this category of patient. So let's start. If the patient, we need to minimize the hypoglycemia. So we've got, alongside metformin, if tolerable, you could use any of these, because all of these 3 cannot cause hypoglycemia: DDP4, GLP-1, SGLT2, and TZDs. Okay, what if the patient, we'd like for the patient to reduce his weight or maintain his weight? We've got only 2 options, either GLP-1 receptor agonist or SGLT2 inhibitors. The last thing, what if the cost is an issue? What if the patient cannot afford a lot of medication. Unfortunately, this is what we face in here, because a lot of our patients, they're laborers, they don't have insurance. So we struggle a lot in this group of patients. In here, unfortunately, alongside metformin, you need to use either sulfonylureas or biglitazone. So to conclude, so type 2 diabetes is, as we said, the prevalence is alarming, as is increasing, and we've got type 2 diabetes is responsible for a lot of complications as premature death, blindness, kidney disease, and the last thing we need to promote the healthy lifestyle, reduce the weight in order to reduce the risk of hypoglycemia and reduce the complication. And as this Dutch philosopher Erasmus said, the prevention is better than cure. And thank you so much.
Thank you, Dr. Sam, for a very nice, impressive lecture. This is suitable for surgeon, not for physician or medical people. As a surgeon, we are facing three problems with diabetic patient. First one, we need to increase durability of our operation, especially after bypass operation as a good treatment for type 2 diabetes. Do you think you can recommend something to increase durability of our operation as regard remission of diabetes after operation? Because you know some operation have recurrence rate increasing time by time. Maybe after 5 years or 4 years, diabetes come back again. So do you have any recommendation about this? The second problem is dumping type 2 or hyperinsulinic hypoglycemia also. What is the proper treatment of hyperinsulinic hypoglycemia post-operative?
Okay, so the first question is the only medication I think, in my opinion, which we could use in this kind of patient is metformin. Because there are a lot of studies now that got licensed metformin to reduce the risk of developing type 2 diabetes in people who they're at risk. So I suggest in these people, they could qualify as a pre-diabetic again, or a high risk of diabetes. So we could use metformin. And here, we could use either the normal metformin or the metformin XR. The dose suggested for the metformin is if you're going to use the normal metformin, which is 850 twice a day, or 750 in terms of slow release. What's your second question, Dr. Tariq? Sorry, I can't hear you.
There is one question here saying, when you can start to adjust the medication after surgery, how soon?
So after surgery, I tend to stop all the medication.
Immediately? Or if the patient was on insulin and
Yeah.
oral medication, so how to do this one?
So basically, what normally I do, so it depends about the patient. So if the patient, they were an oral hypoglycemic, I will stop them post-surgically. And even if the patient after surgery, even if they were on insulin, what I could do, I rely on blood sugars monitoring. So normally we monitor blood sugars very closely, and according to the blood sugars, we could either introduce some insulin if the blood sugars are very high, or might introduce some oral agents. But in my experience with you guys, I did not require to restart any of the patient medication post-surgically. Normally by the day 2 or maximum by the day 3, all the medication, they were stopped.
My question about hyperinsulinic hypoglycemia, Dr. Hussam, how to deal with it?
Yeah, so as I said, primarily we need to adjust the meals. And most of the patient, maybe the dietitian will know better. So this patient, they might require a small portion of food more often. But obviously, we've got other, if they're very severe, we could use some medication like the azoxide and all and other medication. But normally, we don't use them that much.
So I think there's Dr. Mohammed Al-Haddad is trying to ask a question, but he's not writing his question.
Hello, Dr. Abdul Wahid.
Yes, Dr. Mohammed, please go ahead with your question.
Thank you very much, Dr. Hussam. It's a great presentation for a very difficult disease. I have one question. When do you think is the right time to talk to the newly diagnosed type 2 diabetic patient about bariatric surgery, from your opinion?
So obviously, we've got every single patient with type 2 diabetes wants his diabetes to disappear. Obviously, very obese patient who they are qualified for bariatric, in my opinion, we need to talk to them as soon as possible, because what we're trying to do here is not to improve the HbA1c only, but to prevent the further complication. So as I mentioned early on, there's a lot of the patient by diagnosis, but at the time of diagnosis, they have got already complication going on. So we don't want to further delay. So although the patient is newly diagnosed, but he might have some evidence of retinopathy, he might have evidence of nephropathy. So I think, in my opinion, if they are fit, if they qualify for the surgery, we need to introduce the surgery as soon as possible.
So last question here, because we are living in this pandemic of COVID, there's a question saying, any impact of corona infection and diabetes treatment?
Yes, yes. So, so as I mentioned, the last group of the medication, the SGLT2 inhibitors, they're contraindicated. So any patient with the COVID, we need to stop. We need to stop, and he's already on in either empagliflozin or dapagliflozin. We need to stop this medication immediately. And the guidelines said that we might need to be slightly careful by using metformin in patients with COVID as well. But other medication, they're okay.
Thank you very much, Professor Hussam, for this presentation. I think we will go now for our last presentation by our next speaker, who will be Dr. Haider Makki, who's going to speak about marginal ulcer in one anastomosis gastric bypass. Dr. Haider is one of the consultants, recently been consultant, but working in Al-Qasim Hospital with a great experience in the field of one anastomosis gastric bypass. Haider, go ahead, the mic with you. Haider, you are there? Dr. Tariq, where is Dr. Haider now? No.
Okay, thank you.
Yes.
I'm Abdul Wahid.
Very good. Go ahead. Yeah.
Thanks for the ESMBS team. We'll share with you briefly some literature review about the marginal ulcer in main gastric bypass, or the one anastomosis gastric bypass. So, marginal ulcer represents one of the most problematic post-operative complications following any gastroenteric anastomosis. An ulcer or stoma ulcer refers to the development of any mucosal erosion at the gastroenteric anastomosis. Typically, it occurred at the small bowel side. In literature, there is a very variable incidence rate, ranging from 0.6 to up to 16%. Why a marginal ulcer develop? Naturally, we have the protective mechanism in the duodenum. When the food and the acid goes through the enterum to the duodenum, there will be stimulation of the duodenal or the pancreatic protective mechanism for both hormonal and vagal secretions. In cases of bypass, we're going to lose this protective, major part of this protective mechanism. In the one anastomosis bypass, there is so many literature about specifically talking about the ulcer rate or the management of the ulcer in the mini bypass. Most of them based on the review of literature of the ulceration in the Roux-en-Y gastric bypass, especially in the management. And there's recently increased there is fear about the increased rate of the marginal ulcer and the mini bypass, because it's fear of the bile that comes in touch with the gastrogenostomy and the suspicion that it might increase the ulceration rate. From the review of Chevalier, who studied the 1,000 patient result of the mini bypass, he reported a 2% only an ulcer rate. The largest series we found was the one done by Mahar from UK, who done a survey, reported over 270,000 patients with the contribution of 86 surgeons, and finally revealed a 622 an ulcer, giving a rate of 2.24%. But there was a wide variation between the contributors, whether how long they use the PPI, how they describe the ulcer, how they diagnose the ulcer, and how they contribute to the final program, and how they do an endoscopy after the treatment. So, why a marginal ulcer develop? One of the first factors is the pouch size and orientation. From the era of the Rowan-White bypass, they found out the smaller the pouch, the less the ulcer rate, and doing a micro pouch will make an ulcer rate of less than 0.06% over a 3-year interval. So if you compare it to the mini bypass, it should be a higher ulcer rate because it's a large pouch and a longer pouch. But in the study showing a similar ulcer rate. So it was a confusing results. Maybe because doing a longer pouch in the mini bypass, making less tension on the anastomosis, or the bile act like a buffering to the acid exposure to the gastric, neutralizing the acid at the anastomosis site, still just theoretical. And regarding the orientation, you see in this example how creating a pouch by the stapler should be well oriented. In this case, they use a stapler in maybe from the opposite side or in 180 degree, so it was rotated. So when they finalized the anastomosis, it was completely twisted, making pressure and ischemia at the anastomotic site. I have some problem with the computer. Can you see the slide, Ami Abdul Wahid?
Yes, this is good for us. This is full screen. Continue.
Okay.
No, come back again to not full screen.
Oh, okay.
You can make it full screen. We didn't see anything now.
So, can you see it now? Okay.
Yes, okay. We need full screen.
It's not full screen. Okay.
Okay now.
So, anastomosis were twisted, putting too much pressure on the anastomotic side, leading to disruption of the gastrogenostomy and due to an ulcer formation. One of the reasons is also staple line disruptions. Like in this case, the gastrogenostomy was disrupted, and you can see here that was the drain inside the abdomen, leading to the gastrogenostomy exposed to the abdominal cavity. A gastric fistula, leading to acid reflux from the remaining stomach toward the pouch, toward the gastrogenostomy side, leading to an ulcer formation. Foreign body reactions. You can see here the staples of the gastrogenostomy side, or like in our case, they were using an unabsorbable suture material at the gastrogenostomy, leading to an extensive ulcer formation. Thus, the same patient who perforated after 2 years of the surgery came with us with perforated ulcer at the gastrogenostomy site. Still, there are some intrinsic factors, including hormonal and metabolic factors. And the extrinsic factors on the top of them is the tobacco, non-steroidal, and alcohol. They lead to both reduce the reduction in the protective mechanism at the gastrojejunostomy, leading to an ulcer formation. And recently, there's an H. pylori involvement. Some studies mentioning that if there is an H. pylori infection preoperatively may correlate with the development of a marginal ulceration in the postoperative period. That's why it's recommended if you do an endoscopy and you find an H. pylori, do an eradication that might reduce the ulcerate formation post-op eventually. This is the summary of the factors involved. So, in summary, what is the management of the ulcer? On the top of them, we need a regular OGD. In our practice, we advise the patient that after doing any bypass, we do a regular endoscopy at a 6-month interval. After 6 months of the surgery, then a yearly interval. If there is an ulcer documented, we should follow up the healing by an endoscopy, not just by relying on the patient's symptoms. They found that giving a PPI for 12 months to 24 months in the Roux-en-Y bypass, it will dramatically reduce the ulcer rate. In our practice, there's a wide variation about how many months we're going to give the PPI. Some of them give only 3 months, 6 months. Some of them give only 1 month. In our center, we give a 6 months PPI. If the patient is symptom-free, we're going to stop it. For the smoker, every smoker should be advised to stop smoking because a smoker will eventually get an ulcer at the gastrojejunous site. For the H. pylori, in our center, we routinely do an endoscopy before any bypass case. If there's an H. pylori, we're going to eradicate the H. pylori before proceeding to a gastrojejunectomy. And we have to avoid non-steroidal as much as possible. In the study done by Mohaber, they found majority of the patients responded to conservative management with PPI, whether they needed blood transfusion or endoscopic intervention. Only smaller number of patients required surgery, in which 55 patients out of the 622 have perforated, and 59 have a bleeding, in which 1 enterotomy and then the running suture done, and 3 resections and conversion to Roux-en-Y bypass. In the remaining 43 patients who have a persistent ulcer, they were unresponsive to the medical management. I think they exhausted all the surgical options available on the table. 20 were converted, or almost 50% were converted to Roux-en-Y bypass. Some of them underwent revision of the anastomosis, some underwent reversal back to the normal anatomy. Some, unfortunately, ended with a total gastrectomy. 2 of them were converted to a sleeve gastrectomy, and some of them also underwent thoracic vagotomy. With the 3 cases underwent Brown anastomosis. I think the concept behind Brown anastomosis is that they will divert the bile away from the gastrojejunectomy. There is a very confusing pathophysiology about the Brown anastomosis, whether it's useful in the marginal ulcer or not, because some say the acid might buffer the bile might buffer the acid going to the anastomotic site. Others might blame the acid about the marginal ulcerations. But I think many surgeons at this time believe that the Brown anastomosis is not that much useful as the recent literature. So, in our conclusions, suggestion of smoking and a minimum of 6 months PPI is required to prevent a marginal ulceration after gastrojejunectomy. A follow-up endoscopy is required, and the medical therapy is successful in the most of the cases. But it's still for debate. How long we should give the PPI for both symptomatic and asymptomatic patients? And OGD. Still, we should be adherent to an OGD at 6 months after surgery and a yearly interval. If the patients have symptoms, how frequent we're going to do the endoscopy? And is it mandatory that we do eradication to H. pylori for asymptomatic patients before the surgery? Still, there's confusing literature. And OGD for symptomatic patients before the start of the treatment. Should we embark on the on the management of PPI before and documented endoscopy, or should we do the endoscopy only when we have the persistent symptoms? And finally, if the patient is a smoker, shall we do a bypass or shall we postpone the case? I'll leave that for the debate. Thank you very much.
Thank you, Dr. Haidar, for this presentation. We have a question here. First, we'll start with the question of Dr. Badr Al-Hadrami from Oman, who's asking, what is the best approach for marginal ulcer in emergency setting when presented with marginal ulcer perforation? I think control damage, or what do you think, Haidar?
Well, I mean, the best thing is the minimum that you think you can do. Lavage, put a patch, and go out.
Thank you. That's correct. I don't know if Dr. Mohammed Haddad is still with us or not, because I would like to ask him about their approach regarding PPI after Rowan-Y gastric bypass, for how long they will continue. Mohammed, are you there? Or Nazim, you can ask Nazim, what do you think from your side? I don't know, Mohammed, you are there? Or Nazim?
Yeah, سامعني Dr. Abdul Wahid?
Yeah, Nazim, go ahead.
Thank you for the nice presentation from all. Really, I wasn't enjoying. Anyway, regarding the BBIs, you know, I was in Rashid for a long time, and we are also they have a big experience with mini gastric bypass. In fact, we are covering people with BBIs for 1 year, and we don't do any routine endoscopies for patients. And nowadays, I am in the private also. I'm still continuing the same thing. And I have a rare representation of a case who has a bad bleeding after marginal ulcer just 2 weeks after surgery. He didn't receive any BBI, and he shocked at home. He was hypovolemic, and they did it endoscopically, the bleeding. But otherwise, we are covering with BBI. I don't know if we need to do endoscopy. If we can cover them for 24 months, I'm ready to cover them. It's better.
My question, how you are following your patient post one anastomosis gastric bypass? If they are coming with a symptom of reflux or that, you will do endoscopy, and even if they are not coming, are you doing any routine follow-up after 1 year with the endoscopy to see? Nazim? Haidar, where are you?
موجود يعني.
You are there. I think Nazim disappeared again.
No, my mic was off. For patients who are not symptomatic, we don't need to do endoscopy. But the patient who is symptomatic, as any patient who doesn't have any surgery, also we should investigate him by endoscopy. I think so.
So what was any other question here? Who was, I think, the best approach? This is really for how long? There's a question for how long one can expect marginal ulcer to occur after surgery. It can.
Well, I mean, we saw a case that after 3 years after mini bypass, and the second one after 6 months after the mini bypass. So it's variable. Depends, I think, on the patient condition and the symptoms. And there's a lot of factors involved. On the top of them, smoking. The one on the 3 years interval, he was a smoker who could not stop smoking. But the other one, the 6 months, she was a diabetic lady. There is no other symptoms, and there was a very big hole posteriorly in the anastomosis. I think there was an ischemia at the anastomotic site that gradually led to an ulcer and perforated.
Okay, I don't see any other question. For this reason, I would like to thank Dr. Haidar, to thank all other presenters, Dr. Kalhawi, Madam Mariam, Dr. Hussam for their presentation. Thank you all who was with us live on this virtual meeting. I hope you had benefit from that, and we are promising you that we are going to have, let's say, weekly or every 2 weeks a meeting, inshallah. And thank you again for everything. And see you, inshallah, again. Thank you very much.
Thank you for everybody.
Next week we have another meeting. This is by General Surgical Department, Qasm Hospital. This meeting about diabetic food. If you like to know a lot about diabetic food, so we can share us next week, Friday at 9 o'clock. So we have a lot of lecture about it. We have anatomy of diabetic food, guidelines, how to deal with diabetic food from surgical side and from orthopedic, from vascular, and how to use antibiotic in diabetic food. And last, about what's type of dressing of diabetic food. So please, if you are interested, you can share us next Friday at 9 o'clock. Okay.
Well, Dr. Tariq,
Yeah, and the coming Sunday, please don't forget the webinar of the IFSO-MINAC. It's on Sunday. I think you received the message.
If you add the diabetic food to indication for bariatric surgery, you will join this meeting.
Yes, it is one of the indication.
Okay, see you in next webinar.
Thank you. Take care.
Thank you. Bye-bye.